Okay, so we have 9 minutes for questions and discussion. Go ahead in the back. So that was Dr. Howell from Michigan, and he said specifically, how do people in other languages use it? Is there a corollary to functional pain in other languages?
I'd love to hear if somebody knows the answer to that. I barely know English.
Okay. Dr. Keefe. So there's a microphone.
Okay, Elizabeth Keefe, I'm a psychiatrist, and in listening to you describe functional syndromes, I can't help but think about the DSM, which, as we know, is a very fraught manual, but also attempts to describe human phenomena in a way that allows us to say, we think we're talking about X, Y, or Z because of this list of symptoms. And when I think about conversations with patients, one of the things I'm always asking is, do you think this list applies to you? And in what ways is that a useful question? In what ways is that a challenging question? And how do we kind of hold diagnosis in one hand and also throw it out with the other? And so when thinking about functional diagnoses, do we need a different kind of DSM? Would functional diagnoses be approached differently if they were approached more through psychiatry or through consult liaison psychiatry or somatic psychiatry? Or is it just that we need to do a better job of implementing the biopsychosocial model at all times so that we're thinking functionally and really letting our patients tell us what's a disease and what's not a disease?
Lots packed into a fantastic question. So I'm mainly focused on language now. The problem isn't necessarily that you've got something that might be called a functional pain syndrome, but instead that we use functional versus organic instead of idiopathic pain syndrome. So that's point one I'd make. The second thing is, yes, we do need to have a broader model for how to take care of things. And I'll give you just a really quick, this is a TMI territory warning. I'm about to mention my pelvis. Ooh, I already did. I had a pelvic surgery probably 8 or 9 years ago that disrupted my pubic symphysis. I wore a pregnancy belt for a year to try to keep that symphysis from shifting around with not much success. I got my pelvis fused in the front. I had a year and a half before I could walk again, and then I had chronic pain after that. It was pretty awful. By around the end of that time, I started just getting insensitive. I couldn't tolerate bright lights. I mean, even normal lights. I was teaching with sunglasses and a baseball hat on. And I went to ophthalmology and neuro-ophthalmology, got evaluated. And at the end, you know where this is going. The diagnosis was there's nothing wrong with your eyes. Now, I'm slow. It finally just hit me like, oh, right. This is just for my chronic pain. There must be something in my brain that's just caused me to now, I've been experiencing so much of this other pain. It's just taking normal signals and saying that ouch to it. And that's when I started reading and learning about, I got better treatment by using mindfulness training, biofeedback training, recognizing that a lot of joint problems you could see an MRI abnormality might still just be my brain that's over responding to a joint abnormality rather than the joint being the primary problem. How is it that a neuro-ophthalmologist didn't know to think that way? How is it that the person who did my 11th orthopedic procedure didn't look back at the previous 10 and say, maybe the problem isn't in your bones and cartilage anymore. It's in your head. No, it's a bigger problem than that. That's what I would love us to do.
So Peter,
I'll just
add in one other comment and say that I specialize in treating OCD. And one of the features of that particular neuro disorder is the capacity to hyperfocus on all kinds of physical sensation. So many of my patients experience pain, experience physical sensation in a totally, quote, abnormal way. that is completely consistent with their brain.
Thank you.
Peter, this is Rick. Hi.
Hey, Rick.
Thank you. Great talk. I'm going to maybe put an idea out there that could hopefully complement some of your thinking, and I hope you'll continue to write and think about this. The idea of replacing the word functional with idiopathic, I think, is genius.
Yes.
But I don't want to lose touch of something that I've learned from chronic pain patients and in teaching our medical students. We do a session every year about this. Function used a separate way is really, really important because,
Yep.
as you know better than most people, it sounds like chronic pain doesn't just go away, regardless of whether we find an organic cause or not. But helping chronic pain
Peripheral cause.
focus on function is like a different way of using the word function that I think is extremely valuable. So just food for thought there.
Yeah, functional is an important word. It has its function, its role. It's functional disorders versus organic that I think we should get rid of.
Okay, so it looks like there's
Thanks.
2 more questions in the room. Go ahead, Peggy.
Hello, I'm a neurobiologist. So for me, blaming duality for things is great. You know, that's it's easy pickings, but I actually don't think duality is the problem. I think this situation calls for humility. So the problem
I don't have that, sorry.
comes in the verb, you know, there's nothing wrong with you, should be replaced with I don't know what's wrong with you. And then you're done. That's the situation.
Yes.
There's 1 more question in the room.
Hi, Peter. It's Preston Reynolds. Wally
Hey.
Smith at VCU, I would say 15 years ago, started doing research on sickle cell patients, is an internist, sickle cell clinic, health disparities, started the whole initiative at VCU, and started doing PET scans and found that people coming into the ED with a pain crisis, in fact, there was nothing wrong with their joint. It's that over time, their brain had laid down pain tracks,
Totally.
and those pain tracks were getting triggered.
Yep.
But the patient perceived it as pain in that joint. And so the reality is, it is both mind-body connected. And we as clinicians in our current model of care really have very limited therapeutics in how to help patients through this. So I usually refer people who do craniosacral massage and really think out of the box in terms of energy flow and where things are getting kicked or stuck. But there is a lot of research, and I would go to Wally Smith's stuff on PET scans and say that your brain is overworking, and it always has, and it's always been brilliant. And that's what's triggering your perception of pain in the rest of your body. And you're never going to stop your brain working. So we just have to figure out how to help manage the other realities that you're experiencing.
And the good news is there are a lot of modalities that are very
Yeah.
helpful.
So
once you
check out
change
really,
your
really
mind frame.
skilled craniosacral experts.
Oh, I'm good. Just so you know, I'm good.
Okay, well, I think it's time to move on to our next
Thank
speaker.
you.
Thank you very much. Gave us a lot to think about. Our next speaker is Dr. Toll from Oregon Health Sciences and University. She will be speaking about advanced care planning, what needs to be done so that patients' wishes for medical care at the end of life are honored. Dr. Toll is one of our own MacLean Center graduates, and more importantly, she won the 2014 MacLean Prize for clinical medical ethics. She is a professor at Oregon Health Sciences, and she is internationally renowned for all the work that she has done for the portable orders for life-sustaining treatment and for the program for compassionate communication. So she is a huge leader in our field, and we are very excited to hear from her. And again, Dr. Toll, I'll stand up at the 17-minute mark.
It is such a pleasure to be here today. Mark, I owe you so much. This is the 32nd MacLean conference at which I've presented. The third virtually. I wish I could be with you. I wish I could see so many friends and colleagues today. And it's an honor to be invited to share with you what I had the privilege at Mark's invitation of writing in the current issue of the Journal of Clinical Ethics about advanced care planning. After almost 50 years of saying patients have a right to have or to limit treatment, we still have times where it doesn't happen. And I'd like to dive into that for a few moments and see what we can learn about three different important areas where further improvements can be made. I do not have any disclosures. Our Center for Ethics in Healthcare and the Oregon Pulse program, which is housed within our Center for Ethics, never have and do not currently accept gifts from healthcare industry sources, even to avoid the appearance of conflict of interest. I have three objectives today. First is to explore what are we actually trying to accomplish when we have patients, or particularly their surrogates, sign post orders. And do we actually achieve that goal? Second, I'd like to look at risks of ageism and ableism in hypothetical scenarios on advanced directives. And last, I'd like to share two new innovations that help us find and retrieve quickly post orders in a time of crisis. To begin, what are we trying to accomplish by having patients sign post orders? Is it that they are actually writing orders to emergency medical personnel about treatments they want? I don't think so. EMS cannot follow medical orders written by patients. Are we trying to be sure informed consent occurred? A good thing. Does it achieve that? Let's take a deeper look. Oregon is changing for the 14th time, revising the Oregon Pulse Forum in January to try to approach this in a much more, what are we really trying to achieve here? We think it's an acknowledgement by the patient and surrogate that the conversation has taken place and that the orders are in line with what they want. But should we be requiring signatures to patient surrogates to sign? That's a real question. And does that achieve a goal? Does it assure that informed consent occurred? There have been several reviews, including ones that we did in the late 1990s, about patients' decision-making that needed to be done by surrogates to limit treatment. A study by Windler found that about 1/3 of surrogates report serious symptoms of distress, doubt, guilt, waking up at 2 a.m, wondering if they hadn't authorized withdrawal of life support. Whether it's what their loved one really wanted, would their loved one be alive? Were they the one who pulled the plug? Are we putting too much responsibility for this decision, heaping it on the shoulders of surrogates? Now, certainly there are surrogates who go, I know what dad wanted. I am really glad to sign this form and stand by his wishes. It's not universal. But there are altogether too many surrogates who feel substantial guilt, and it may be worse, by our requiring signing. So what do we get for the signing? Does it verify informed consent? Is it being done primarily to offer legal protections? But does it achieve the goal that patients actually had a real conversation, understand the choices, and that the choices are in line with the patient's wishes? There's some real questions as to whether it achieves that. In a study by Stevens out of California, almost all the nursing home residents in the study had POLST forms. But interviewing surrogates, most did not remember having an advanced care planning discussion or signing. Now, the context was that the POLST form was part of an admission packet to the nursing home where lots of documents were being signed, and the quality of the conversation may come into question. In our new Oregon POLST form, we are making a change to look at the fact that there are so many people who benefit from having a support person with them for the conversation, that it isn't you're perfectly capable of independent decision-making or you have no decision-making capacity and someone needs to decide for you. There are plenty of people who, with support, mild cognitive impairment, developmental and intellectual disability, but with a support person present, are able to contribute to, participate in, and in some cases actually make their own healthcare decisions. Oregon's statute has changed to formally recognize the role of a support person who might not be the power of attorney, the person legally appointed on documents, might be someone who assists and cares for them in a group home. And the person wouldn't have any authority to actually sign a document as a surrogate, but plays a vital role in supporting decision-making. We will be very interested to see, as we make this change and mandate that you have to say who was present for the conversation, or the forms will not be loaded into the Oregon POLST registry. Because about half of people who die in Oregon have a POLST form in the registry at the time of death, and others have a POLST form that's never entered into the registry. We will be able to gather about a month after forms are entered how often each category is marked. We will know if an important support person, such as the power of attorney for healthcare, was not included in the conversations in a patient with a certain level of cognitive impairment. This will encourage the appropriate use of support persons for people who need them, and begins to really put pressure on the quality of the conversation and assuring that the right people were present for the conversation. And of course, that never does a conversation occur without actually the patient or surrogate being aware of a conversation. So in January, we're implementing the 14th version of the Oregon POLST form with these changes. In an ongoing quality assurance activity to continue to improve the quality of the form and to promote public trust and address the possibility of bias, the next objective. Advanced directives, now moving away from POLST in part to thinking of more traditional advanced directives, in some states, including my own, have hypothetical scenarios. They have scenarios that talk about conditions you do not have. And overall, people tend to be members of our society, the patients making these decisions, the healthcare professionals guiding them in the decisions, and bringing with them a lot of ageism and ableism to decisions that perhaps later they will find more acceptable than they had anticipated. We recommend in our article in the Journal of Clinical Ethics, current issue, that hypothetical scenarios not be part of advanced directives. They also increase the chance of, for example, order combinations that are not recommended by most professional bodies, like the placement of a permanent feeding tube in persons with advanced dementia as an option of choice. We need to guard against and be very aware of the bias in the care of people with disabilities related to completion of POLST forms. POLST is not intended for people with long-term stable disabilities. It is intended for people who are nearing the end of life, who may or may not have a disability. Deeply concerning is research published in Health Affairs last year that examined physician perceptions of people with disabilities and their care, and showed that a landslide majority of physicians viewed people with disabilities as having a lower quality of life than non-disabled people, and lower than what people with disabilities viewed their quality of life. So this note of caution and the recommendation of getting rid of hypothetical scenarios, which include on a POLST form, what may be a hypothetical scenario about whether or not you want a permanent feeding tube, unless you have something like Lou Gehrig's bulbar form, where that would be part of the disease trajectory. But making a decision in advance of a stroke that you haven't had yet and knowing risk and benefits may fall into the same category of bias that is unwise as a hypothetical scenario. The last objective is 2 new innovations in Oregon. The first, rolling out this month under the leadership of Dr. Abby Dodson, who directs the Oregon POLST Registry, is an app to go on EMS iPhones and tablets where they can search the registry in the field and identify whether or not a patient should be intubated, and make it clear in the process of transfer if a patient is do not resuscitate and comfort measures only, but comfort can't be managed in the current setting of care, alerting the emergency department in advance that the issue is comfort focused, not a patient who wishes, for example, to be admitted to the intensive care unit or to have CPR en route if an arrest were to occur. The second innovation recognizes that about 6 years ago, a study at OHSU found that the majority of POLST forms on patients coming into our emergency department were not reviewed in the emergency department. Other studies have found similar problems of patients with limitations on treatment being admitted to intensive care without review or identification of their POLST form, and often later discovering it is not the care and treatment they wanted. We implemented a protocol in the nursing triage protocol, which starts out vital signs and so on, and placed a pop-up in that protocol for patients 80 and older, because the rate of POLST forms and limitations on those pulse forms is so high in that patient population for an initial pilot. In 1 year, one patient with do not resuscitate and comfort measures only was missed and admitted to the ICU. Even with float nurses and all the challenges of the pandemic, the protocol did substantially increase the number of patients identified with pulse forms and limits. When they're identified, it is put into the advanced care planning tab, and the rest of the team is alerted. I welcome further questions, your thoughts, and any questions we don't answer during the question and answer period. I would welcome the question being sent to OregonPulse.org. We're happy to share what we learn, and we're happy to learn from all of you. Thank you very much. I welcome your questions.
Thank you very much. That was awesome. Dr. Ross and Dr. Siegler, they get the first two. Dr. Siegler gets the first one. Sorry, go ahead. Do you want to come up here so she can see you?
Yes. Yes, Mark, I want to see you.
I knew she did.
I want to see you, Mark. I miss you.
I just have one question for you, Susan. POLST, which stands for Physician Orders for Life-Sustaining Treatment, as far as I can tell, has now been adopted by 45 or 46 states, of course, including the state of Illinois. I wonder if I could ask you to tell us who initiated the field of POLST.
Mark, you are very sweet. POLST was launched in Oregon in 1991 and became statewide in 1995. And we now call it Portable Orders for Life-Sustaining Treatment in Oregon, honoring our colleagues who are advanced practice nurses, our PA colleagues who also sign. About a quarter of pulse forms in our state are signed by other than an MD or DO. But Mark, thank you so much, and I miss you so much, and you've done so much to advance our work, my career, and open doors of opportunity for so many of us. I miss you.
Dr. Ross. You can come up here.
Hi, Susan. Lainey Ross.
Hey, Lainey.
So I know I'm an N of 4, and that, so I take a minority position, but I always worry about families being in the room, and I worry whether the patient has asked for the family members to be in the room, and what type of protections are there, because we both know that we've met patients who will say one thing in front of their children and say another thing when their children are asked to leave the room.
Lainey, you couldn't be more right. That when we talk about a support person, it's offering a support person. It is not requiring a support person. The statute for certain people with disabilities does require a support person be offered to the patient, but the patient can opt out. And we occasionally see surrogates, appointed or not, who hold a different view from the patient and are not as respectful as we would like them to be of empowering the patient's decision-making. Your points are well taken.
Thank you.
Go ahead.
Hi, Susan. This is Chris Springer. I'm also from Oregon. Very good to see you. Question around the removal of this requirement for the signature. That fascinates me. It's an issue that has come up at my own institution. Did that discussion come out of people who have completed the POLST, concerns that they had expressed, or you all as you were just reviewing the form? I love that you've had 14 iterations of it. Thank you.
Oregon has never in 30 years required the signature of the patient or surrogate. We've called it different things, but we have, and the word acknowledge is new on the new version of the form. But we had always had reservations from day one that we were putting too much burden on the surrogate. We've done studies in Oregon so far back, we already knew that surrogates could be unduly burdened in some cases. So many other states mandate a signature, and we're hoping to assure that informed consent occurred by mandating a signature. Some of them may have legal colleagues who thought that would be helpful in protections by having a patient signature, but actually Oregon has never required it.
Okay, thank you very much, Dr. Toll. That's going to be our last question.
What an honor. I miss you all.
Thank you for your time. We really appreciate it. Our next speaker is Dr. Lazaridis. He is going to be talking about algorithmic shared decision-making in neurocritical care applications. Dr. Lazaridis is a neurointensivist who specializes in the management of severe traumatic brain injury. He has co-authored over 100 peer-reviewed manuscripts, and he is an associate professor in neurology and neurosurgery at the University of Chicago and one of our favorite faculty member of the MacLean Center.
You're my favorite. Okay, thank you very much for this invitation. I have to say, so I put an asterisk there for algorithmic. What I'm really saying is decision theory informed. The problem is I don't know very much about decision theory. And I like previous speakers said they did summer research on their topic. So this is my summer vacation research on decision theory. But this is a talk for collaboration. So if decision theorists are out there interested in these questions, I would love to talk to them. And the example I'm going to use, the case study, is the decompressive craniectomy in traumatic brain injury. Okay, so this is the standard model of recommended shared decision making in critical care, I guess neurocritical care in this setting. The idea is that you receive a patient who is comatose after acute brain injury. They are on multi-organ support. You, of course, perform resuscitative measures, possible surgery. You try to optimize all organ function. And then over a number of days, you engage in these meetings with families and surrogate decision makers. And the idea is that, is that a pointer? No. Is there a pointer on this? Maybe not. So the idea is that you see these gray circles there, identify the features that have to be incorporated for high quality shared decision making. And so things like, of course, you know, communicating the medical facts of the situation, trying to give some prognosis, and then importantly, eliciting preferences, values, goals of the patient at hand. And of course, this is done indirectly, either usually we are talking about mostly young patients who don't have living wills or previously expressed wishes many times. So you have to elicit that through, you know, loved ones and surrogate decision makers. And so eventually a choice has to be made. The problem with this model is that it doesn't actually discuss the nature of choice. And that's where decision theory comes into place. And I've had hundreds of family meetings in my short career, but I only recently learned about decision theory. So I want to try to rectify this in some way. Okay, so we are not told anything about uncertainty in two ways. What is the nature of uncertainty? And I'm not going to talk about this today, but also the technical nature of uncertainty as a condition during decision making. And I'm going to talk about this in a minute. The obvious fact, we are all bounded, you know, bounded rationality of the people who are participating in this. In fact, somebody I think said we're predictably irrational. How about decision architecture? So these are terms that come up, and you know, they're so fancy and interesting, and I'm so surprised that we engage in decision making all day long, and they are new, at least for me. decision quality and decision regret, exercises in values clarification, nudging. And so I think one day, maybe I'm going to call this the quantum model, just for the analogy of physics here, that one day we're going to have a behavioral economics decision theory informed SDM. Okay, now cognitive biases, right? And that comes from behavioral economics literature, of course. So what are they? They can affect certain decision making by distorting the understanding of the nature of a certain choice or decision and the foreseeable consequences. There are a lot of them. Some of them, for example, the impact bias, the failure that we all have to anticipate how things will look or feel in the future. This relates to the disability paradox that was already mentioned earlier. Gain framing, you're given the same choice, but the way it is discussed, contextualized, framed, the language used may determine what choice is made. And this is very relevant for this kind of thing. For example, if you emphasize on life-saving versus emphasizing on quality of survival, you may get a different response from the family. And I will also say that gain framing, I think sometimes is intentionally exploited, maybe that's not a good word, by clinicians when they feel that a certain course of action has to be taken. You can gain frame things to maybe get there or convince a family. Sometimes this is good, sometimes this is bad. Optimism bias. So that's been well documented in the general critical care literature in situations of disagreement between families and clinicians about prognosis. It's not just misunderstandings or lack of knowledge. It's just the simple fact that families tend to be more optimistic. So this is a long list of cognitive biases. An incredible book that I'm reading right now is by Jennifer Blumenthal Barbie, who is a philosopher and medical ethicist in Baylor. And she has done amazing work in trying to bridge these two worlds of behavioral economics, decision-making theory, and medical ethics. And this is a short, absolutely fantastic book, and I would recommend it. Okay, let's talk now about informational conditions that settle what kind of decision problem you're facing. So one is of certainty, not very interesting. Everything is known about this choice, the true state of the world, the options, and the outcome. That's not our case. Now, a subtle difference between decision of risk. So here, this is like lotteries or in casino, in roulette. The probabilities of your action are known in the sense that they're mathematically derivable, right? So you can assign a certain probability number. More often in medical decision making, we actually have uncertainty. And here, it's interesting, one way to define this is situations where one can only have probabilistic beliefs about a range of possible outcomes. That's the technical definition of uncertainty in decision making. And then finally, ignorance. You know absolutely nothing about either what the outcomes may be or what the probabilities are. Okay, so what does decision theory say? Some very basic principles. So it's concerned with the reasoning underlying an agent's choice, and this can be very mundane choices. For example, you woke up this morning and I just found these shoes and I decided to put them on. This could be a decision choice there, and very far-reaching. So for example, to pursue a certain career, or in my example, to pursue a decompressive craniectomy. The focus here is normative decision theory, so how people should make decisions. Very famous work here goes back in the 70s, Kahneman and Tversky, where basically they did a lot of work in descriptive decision theory. And then they came up and they described all these mistakes in rational decision making in the form of cognitive heuristics and biases. And so the key issue is the treatment of uncertainty. And to put it in a sentence, how to choose rationally, and this is instrumental rationality, right? How to best match means with ends. When you are not sure which outcome will result from your acts, very common scenario in high stakes medical decision making. And the orthodox normative decision theory is expected utility theory, which basically says when you're uncertain, prefer the option with the greatest expected desirability or value. Okay. How is this calculated? So one is that one needs to assign certain degree of value or preference ranking into possible outcomes, right? And this is expressed with a number called the utility. And then you need to have some sense, a belief, some degree of belief about the probabilities of that certain outcome happening. And once you have that, you put together the sum, like a function of probabilities and outcomes and the utility of each outcome. And then you can actually come up with a numerical estimate of the expected utility of a certain action. Here's a case, and I know this is, we're going to do more ethics than neurocritical care, but what you're looking at is a CAT scan of a young person with severe traumatic brain injury. They have refractory intracranial hypertension, and there is a very precise clinical question here. Do you offer a decompressive craniectomy to this person or not? And this is a decision that, it's not, I wouldn't say it's hyper emergent, but it's urgent, right? It has to be made within an appropriate time window to optimize outcomes. This is how the skull looks without the bone. Okay, so what you would do in standard terms is that you need obviously to be familiar as a clinician of the relevant literature. So you would go back and say, what are the best randomized, highest level of evidence you have to address this question. And then you would read the DECRA trial from Australia and New Zealand, performed back in 2011. Then you would read the 1-year outcomes from this trial. And then you would also read the rescue ICP trial from Europe, 2016. And then you would read what was published last year, which is 2 years outcome after the trial. So this is the cognitive armamentarium you want to have going into this discussion. So then typically what you would do is you would sit across these family members and you would say things like this. So the 1-year outcome data show a non-significant trend for worse functional outcomes. What's this, right? Non-significant worse functional outcomes. You would also say things like unfavorable outcomes after decompression were 11% greater, but not significant. Among survivors, you can even become more numerical now and quote from the abstract and talk about odds ratio of what happens. Then you can talk about the other trial, the Mauritian one, the rescue one. And here things get even more complicated. Why? Because there are different statistical ways of reading the trial in terms of how it was dichotomized between favorable and unfavorable. Right? And all of this, mind you, is done with, we're talking about favorable and unfavorable outcomes entirely from the investigator standpoint. The patients, families, nobody ever asked them, right? I mean, what exactly is favorable and unfavorable for you? So this is the statistics. This is how you would conventionally talk about this. Look at the last statement. So surgery basically, for every 100 patients with surgery, there is 20 additional people who survive. So this is a procedure that has a very significant mortality benefit. It reduces mortality, no question about it, right? The problem is that these 20 people who survive have a spread of various degrees of disability. And just my point here is that this is a very nuanced result, I think even for experienced clinicians to kind of understand and digest. I cannot imagine how complicated it must be for a family to understand this under all the stress of the decision. Okay, so what does the best minds out there in this say? They say that they write editorial in New England Journal of Medicine. They say, well, quality of life is an individual determination. And it's important to engage surrogates in discussions that focus on patients' previously stated wishes and personal values. Thank you very much. That is so useless. How do you do that? How do you do that? And they call for the development of more refined clinical decision-making tools, although no such account has been offered. Okay. All right, so this is an experimental idea here, okay, and may be completely wrong. Or it could potentially be developed somehow. The idea is go back to expected utility. And when you sit down with a family, try to get some sense of a preference ranking of different disability levels. Like the same way we score disability at the end of the trial, we use the Glasgow Outcome Extended Scale. Try to figure out the best you can in this context, in this difficult context, how the individual would score from 0 to 100 each individual level. I know there's tons of caveats here, okay? But the idea would be, in the ideal world, you would have a preference ranking of individual disability levels that can be used as the utility value in your EU formula. So once you have that, I'm sorry, this is not supposed to be read, just to give you an idea of how this would work. Then you would take this best evidence from these clinical trials and use the observed outcomes in the trials as your probabilistic beliefs about what may happen to this individual. And that's how you can calculate, based on the individual's preferences, if surgery versus no surgery would be the optimal strategy. We wrote about this and kind of presented just a sketch of how potentially this could happen. And this is just a summary for the paper. It's not very important. So of course, there are very many limitations here. So it's like you're presenting some kind of a calculus that you go from, okay, what are try to do some values clarification, get a utility ranking of preferences, and then you come up with a numerical thing, which feels very odd in medical decision making, that you would have a number to decide yes or no surgery. There is large scale limitations. So if you're gonna ask someone to rate their preference rankings from using a validated scale, these scales are very crude in the sense that they talk about you can be left alone at home for 8 hours, but you need help with walking outside. They are very brief, crude descriptions of disability. The disability paradox, you cannot avoid it, right? It's if you ask me my utility preference ranking now, I have no doubt it's going to exhibit bias towards less disability than I could potentially find acceptable in the future. No empirical data for this, at least in this field. There may be, it's very possible there's an entire studies of this in other fields of medicine. But at least the answering this kind of questions in my world, there's no empirical data. So we need to try to get a feasibility study or something. Is this realistic in acute settings? Can you have this kind of, in a decision of high stakes like this, can you actually have people to have the enough concentration to put together a preference ranking, for example? Plus, remember, they're deciding for a loved one, or they're not deciding for themselves. And then finally, this may be completely unacceptable in certain cultural norms of communication and certain decision-making preferences. So I've almost convinced myself out of it now, but I still think that there may be some merit in this, and I think that's all I have to say today. And thank you.
Works, and I think that you were highlighting this on your conclusion slide in the current age of medicine. And Dr. Siegler, I'm gonna quote your 3 ages of medicine from a paper here from 1984. I have it in front of me, but there's the age of paternalism from 500 BC to 1965. The age of autonomy from 1965 until 1983, and you can go into the paper to see why that was chosen. And the current age of bureaucratic parsimony. In the new system, decision-making will no longer be in the hands of physicians or patients, but will be biased upon institutional and societal efficiency or expediency, and upon cost concerns, all emerging rapidly as elements in decision-making. There's clearly external factors too, and I think it kind of highlights, is this reasonable in an acute setting?
It's the age of the machines, artificial intelligence, and yeah, maybe, I don't know, were you suggesting that there's some degree of paternalism, maybe play it? No, okay. Yeah. Maternalism, maybe. Of course, yeah. Yes, cost, so adding cost utility into this. A fair bit. A fair bit. Yeah, I guess even, even before that, should it be part of something like this? Cost. It sounds like it should be. I mean, what the healthcare system can accommodate potentially, and what actually families can have to spend for care. And yeah, I think that would complicate things significantly. Thank you.
Thank you very much. Our next speaker is Dayan Meach. He's going to talk about how nutrition helps shape the field of modern bioethics. He is an associate professor of medicine, also at University of Chicago in internal medicine and GI, and he focuses on the role of nutritional support and clinical ethics from a historical perspective.
So thank you for the invitation. Good afternoon, everybody. I was encouraged to do the Fellowship of Medical Ethics here in that 2019 and 2020 academic year because I have a clinical interest. Where's the button? Is it? Yeah. Because I have a clinical interest in this idea of nutrition support, which is really the use of parenteral and enteral nutrition. Clearly, as we've seen even just in this last talk, ethical dilemmas come up in this field. And ultimately, this was some of my interest in pursuing the fellowship. Now, last year, I spoke about some work that we were doing related to the use of parenteral nutrition in the late stages of cancer. And this year, I wanted to expand on really the importance of nutrition-related topics in clinical ethics. I hope to show how poorly nutrition support and nutrition-related topics are understood by most physicians, with a goal of widening training in nutrition support so that maybe we can avoid one or two of these complex end-of-life clinical scenarios. First, in the outline here, I will discuss the duty of the physician to preserve life support and historically where this came up. In a few slides, I want to then touch on some of the famous cases in clinical medical ethics, simply to show where nutrition support played a role in those cases. We will then discuss the role of the physician when it comes to medical decision-making related to a gastrostomy or a PEG tube placement. And I hope to close by showing some deficiencies in physician knowledge related to nutrition support. My goal would be that ultimately, through a broader understanding of the field that I work in, that we can improve the communication of physicians with patients. So let's ask a few questions. The first would be, what is the duty of the physician? Is it to prolong life and to reduce suffering? If it's to prolong life, by what means should we be using it? Is there a difference between ordinary care and extraordinary care? If the role of medicine is to prolong life and reduce suffering, these at times can act in opposite directions. Invasive procedures can increase suffering but prolong someone's life. And in the opposite sense, not performing life-sustaining procedures can decrease suffering and reduce the duration of life. So let's explore a little bit more historically where these concepts came from. What is the physician's duty in their practice to preserve life? Darrell Amundsen, a professor of classics in Washington State, asked this very question in a report for the Hastings Center in 1978. And looking back at the Hippocratic Corpus in a treatise entitled The Art, medicine was defined as having three roles: to do away with suffering of the sick, to lessen the violence of disease, and to refuse to treat those who are overmastered by their diseases, realizing that in those cases, medicine is powerless. Now, Professor Amundsen then goes on to show that this was the overwhelming sentiment into the Middle Ages or the late 1400s. And it was in this period that universities were developed, specialties were growing, guilds were created, they started to have ethical codes, licensure was required in some fields. This led then to the first written evidence supporting the role of a physician to prolong life from Francis Bacon, an English philosopher and statesman, who wrote that medicine can be divided into three offices: the preservation of health, the cure of disease, and now the prolongation of life. We can see almost how the duty how the duty to preserve life arises in the Middle Ages. Essentially, it becomes that third pillar of medicine, which changes from the refusal of care in those that are approaching death to the prolongation of life. Now we can see where this concept arose, and the next question then comes up to be as to what costs should physicians attempt to preserve life? This was historically most often debated in writings from the Catholic Church. And there was a lot of terminology used on the differences between ordinary and extraordinary care. Most famously, this comes up in Pope Pius XII's address to the Congress of Anesthesiologists, where he defines ordinary means of support as ones that do not involve a great burden on oneself. But this is a difficult concept to adhere to, as with time, ordinary procedures become more common and become more ordinary with time. What is really lost is the original definition of these terms. Ordinary and extraordinary were first described by Father Bañez in Spain in 1595, who bases the terms also in the proportion to one's state in life. And this is a significant point that is often lost. Just as on the last slide, where the role of a physician loses sight of the state of the patient, the underlying condition of the patient is also lost in the terminology related to treatment extent. Obviously, prognosis making is difficult, but we're losing sight of the patient in end-of-life decision-making. Now, this leads me to some of the famous cases in clinical medical ethics, and I need to really review these just in brief order. The Karen Ann Quinlan case was in 1975, where she was involved in a motor vehicle accident that left her in a persistent vegetative state. Her parents requested that she ultimately be removed from a ventilator, in contrast to the opinion of her court-appointed guardian. And ultimately, a New Jersey Supreme Court ruled in the favor of the parents, allowing the ventilator to be removed. The only issue was that the feeding tube, the nutrition support, was left in place, allowing her to live an additional 9 years. In Barber versus the Superior Court of California, 2 physicians were actually charged with murder for discontinuing a ventilator and feeding tubes from Clarence Herbert, who suffered a cardiopulmonary arrest after a simple surgical procedure. While he did not have prior advance directives, the family requested in writing that the ventilator and feedings be removed. Ultimately, the charges were overturned and it had to go to, I think, 2 appeals courts, as the omission of a treatment was not considered a failure to perform a legal duty. The third case in 1984 was of Claire Convoy, an 84-year-old female that was a resident of a nursing home with dementia and comorbidities of hypertension, diabetes, and heart disease, also in New Jersey. She was in a contracted position, and her legal guardian, who was her nephew, asked that the nasogastric tube for feeding purposes be removed. This was initially allowed and then overturned in an appeal, and during this time, the patient had actually passed away. Ultimately, the case went to the New Jersey Supreme Court that ultimately allowed the feeding tube removal in the past tense, where they acknowledged the right of a competent individual to decline treatment, and now they extended these rights to an incompetent adult. Lastly, we have the case of Nancy Cruzon, who at 25 was in a motor vehicle accident in a persistent vegetative state in 1983, very similar to the Quinlan case. 5 years later, her parents asked that the feeding tube be removed and filed a court order given the hospital's refusal. This was the first right to die case heard by the US Supreme Court in 1989, and the court upheld the requirement of the state to require clear and convincing evidence to be produced for a treatment withdrawal, which the parents ultimately provided. Now, from these cases, we can see the role of surrogate decision makers, advanced directives, individual state requirements, but what else is common and never discussed? That the feeding tubes were already placed. What were the discussions surrounding their placement? I can find no information or data related to that topic today. So here we are in the mid-1980s. This was a very active period in the time of the topic of withdrawal of life-sustaining care. Therefore, and Dr. Siegler and I discussed this on Monday, I think, or Wednesday, had his own opinions expressed in a paper in the Annals of Internal Medicine in 1984, just as that Conroy case was progressing to the New Jersey Supreme Court. Responding to 2 articles on the legal aspects of withdrawal of care and an article on the basics of nutrition support, Dr. Siegler and Alan Weisbard called for a reining in of the eagerness to withdraw care in the majority of cases, noting that ultimately patients will be protected, physicians will not have to make ad hoc decisions, the medical profession will be preserved, and most importantly, that the larger interests of society will be preserved by not singling out potentially undesirable groups. And that can be some of the harm of withdrawal of care. But now for me, as discussed, the missing piece is the lack of clarity related to nutrition support and the decision, that initial decision to pursue gastrostomy placement. As discussed in one of the Annals papers, nutrition support, whether it's through a G-tube, whether it's through an IV, should not be dismissed as some simple, automatically applied component of healthcare. A decision to pursue feeding or hydration should undergo the same analysis that we use for starting and using a ventilator and starting chemotherapy in a patient. This leads to a paper from Dr. Toll, who we just heard speak in this section, from 1995, highlighting the themes from family interviews of patients that required end-of-life decision-making, and she highlighted some of this. Helpful themes that the families expressed included doctors that encouraged advanced care planning, timely communication, clarification of family roles, and facilitating a consensus. What was harmful was postponing discussions related to withdrawal of care, singling out family members, and shying away from family care discussions. These are the topics that we need to consider when approaching a family and staying with them during this end-of-life decision-making, but is it really happening? In a retrospective study from 154 adults in South Carolina in the field that I work in, the medical records were reviewed in individuals undergoing a gastrostomy placement. Only one patient chart had clear documentation of the benefits, burdens, and alternatives to gastrostomy placement. Furthermore, even among likely competent adults, consent was obtained often from surrogates as opposed to the patients themselves. We were bypassing the process. Similarly, in an interview-based study from Canada, nearly half of surrogate decision makers were never provided a patient prognosis, and we saw this in the last talk. In the most severe cases, a quarter reported getting conflicting prognosis information. The majority of surrogate decision makers offered prognosis expectations that were better than that the physicians expected. Clear and accurate discussions, therefore, are either not occurring or not being properly documented or interpreted. So this gets me to the last part of my talk, which is related to nutrition support. And I have a fellow back here that's probably laughing. If we can train physicians to be familiar with nutrition support and with the placement and use of feeding tubes, maybe we can facilitate some of these discussions that happen daily in the wards and in the ICUs. My favorite question to rounding residents, fellows, and students to gauge their basic knowledge of chemistry and to gauge their basic knowledge of what we were providing these patients, normal saline. This is something provided in the first day of internship. How much sugar is in a bag of D5W? How much salt is in a liter of saline? How many calories in a simple can of Ensure? These are very basic topics. I'll just go over the questions, not to pick on anybody here, but it's 50 grams of dextrose, which is 150 calories. It's 9 grams of salt, which is twice the amount that we would ever recommend to a cirrhotic or a person with heart failure. And it's 1 calorie per milliliter for most enteral nutrition formulas. So anywhere between 250 and 325 calories. Very, very, very basic, and it's overlooked through all of training. So when I argue that we need to improve training and nutrition support, maybe most people would point and say that it's a failure of the medical schools and argue that more training needs to occur there. But I would disagree and argue that it's a clinical specialty that requires hands-on training on the wards and in face-to-face patient care. In a survey study from Emory, students were asked to judge the importance of nutrition counseling in their planned careers. Medical students at the time of orientation on the left bar all thought it would be important, but this interest clearly declines by the time that they're applying for the residencies. Obviously, career interests change and arise, but students are not exposed to nutrition-related care in the hospitals, and this is where it needs to be. So where should we teach nutrition? Really, it's in the hospital setting as part of a multidisciplinary nutrition support team, which we thankfully have here. This was evaluated in a 1991 study from Alabama during a period of time when certification nutrition was a medical specialty that was being sought. The authors tried to identify factors related to a functional and effective nutrition support team, and those really came about from a few points, which was that there was a multidisciplinary nature of the service. The teaching component of the service was valued. There was strong physician leadership, which unfortunately we are starting to lose because of a lack of active training programs. So how can we tie this into the rest of the talk, and why would it matter? If we can teach physicians what they are providing patients, maybe it'll influence their decisions in end-of-life care. In a Japanese study that included a case vignette of a patient with gastric cancer and an inability to tolerate oral intake and an expected survival of 1 month, physicians that had positive attitudes of intravenous hydration were significantly less likely to be involved in palliative care or have experience in end-of-life care. And they were more likely to believe that hydration was effective for symptom palliation. If we can include nutrition support training really in most or all medical specialties, maybe we can return to some of my original slides on the role of the physician to prolong life. We can hopefully change that role simply from the prolongation of life, but return to the ideas that include the prognosis and context of the patient. So therefore, in conclusion, we highlighted some of the cases related to withdrawal of life sustaining care, and these are the cases that generate the most notoriety and are brought up in the news. There was a fear of over-extrapolation and withdrawal of care that, in addition to the ideas of prolongation of life, we're in a period of time where discussions and experience with end-of-life care are lost. I didn't really go too much into it in this talk, but from the question here in the last talk, I hope to discuss it more next year. We're in a period of time that is driven by hospital cost factors and a loss of the physician-patient relationship. I hope, but I'm pessimistic about this idea that we can return to care that includes patient prognosis, established relationships with patients, and a multidisciplinary model of care, given the complexity of medicine today. And with that, I hope to take any questions.
You have 5 minutes for questions.
Thanks.
Hi, my name's Carly Haug. I'm one of the current fellows. I'm at the University of Wisconsin, and we're currently doing a study at a hospital where there was an automatic ethics consult for any patient with dementia in which a feeding tube was requested. And over time, they just don't place feeding tubes in those patients anymore. And so I was wondering if you could comment on like culture and the impact of clinical momentum in feeding tube placement or feeding in general.
Yeah, I mean, I think it would be a wonderful model. I'm trying to kind of start to look at different types of models of feeding tube placement, because it's one of the issues that we're really running into now. You know, from a technical procedure, it's a very, very simple and easy procedure to do, but the difficult thing from my standpoint would be the prognosis of the patient going forward. There's so many things that are involved in the prognosis, whether it's a cancer, whether it's neurology, there's so many different disciplines that are involved. And having a few key stakeholders in that discussion, I think would really be important. I've heard Mayo potentially does a similar model that does some sort of multidisciplinary assessment before a gastrostomy is placed. And there's some studies from the United Kingdom that have looked at and shown a reduction in gastrostomy use when there's a multidisciplinary model. You know, unfortunately, at our hospital, we've created a model where there's a combined placement of a feeding tube and a ventilator, or a ventilating tube, a trach and a peg, more to reduce length of stay as opposed to actually improve outcomes for patient care. And so, you know, there's a balance here ultimately. And I think that multidisciplinary model that can somehow meet and round on a regular basis really would be important. The multidisciplinary nature of a nutrition support team includes pharmacists, dietitians, nurses, fellows with a wide variety of experience. And so we do try to weigh in some of these cases, but having expertise from neurology, from oncology, from other services really would be beneficial. So I think trying to gather a list of these hospitals that are doing something like that really would be important. Cool. Thank you.
Okay. For people who are counting, 2 more talks to go until break. Our next talk is Dr. Luke Gada. That's our timer going off. He's from Duke University. He's going to talk about the placenta. Is the placenta a friend or a foe? And he's talking about the principle of double effect at the maternal fetal interface. Luke is a senior MFM fellow at Duke University. He is one of our most recent MacLean Center fellows, which is exciting. And he will be faculty this summer in OBGYN, as well as at the Vanderbilt Center for Biomedical Ethics and Society. You have a job. Congratulations.
There we go. Yeah. Thank you. Well, good afternoon. Dr. Angelos, Dr. Seeger, members of the MacLean community, thank you for allowing me to speak on this very important topic. So I have no disclosures, but I do want to thank the patients that I spend many of my nights with on labor and delivery who've taught me quite a bit, especially the patients that are going to be presented here. These are hypothetical cases, but I'm first going to discuss the dual identity of the placenta as a potential friend and a potential foe. Next, I'll briefly discuss the principle of double effect, and then we're going to apply this within a hypothetical obstetrical case of Ms. Smith. And then we'll propose the term placentectomy and conclude with a brief description of the strengths and limitations of this ethical framework. The placenta is essential for childbirth, typically forming with blastocyst implantation into the endometrial lining and then separating from the uterus after delivery. It allows for maternal blood to come into close contact with fetal blood without admixing in order to supply oxygen and remove resultant carbon dioxide from fetal circulation. Fetal development is dependent on placental physiology, which itself is dependent on gravid physiology. Similar to other organs, the placenta requires adequate function of other bodily systems, such as a sustainable cardiac output or glomerular filtration, in order for the placenta to survive. To each end, to the fetus and to the gravid patient, the placenta is a means with different potentialities. To the fetus, it is designed to supply oxygen for aerobic metabolism. It is predominantly life-giving. For this discussion, we're going to consider it a friend. To the gravid patient, the placenta demands aerobic metabolism, up to 1.2 liters of blood per minute in a term pregnancy. This is how much a liver gets. Its stress on physiology is potentially life-taking or a foe. These two potentialities, friend and foe, are inextricably linked during pregnancy, albeit inversely. For example, as the gestation advances, the life-giving potential of the placenta increases for the fetus as it approaches term. Inversely, as the gestation advances, the life-taking potential simultaneously increases for the gravid patient, as cardiac output must progressively increase to meet metabolic demand. Pregnancies are commonly tolerated because the life-giving potential of the placenta exceeds the life-taking potential in an otherwise healthy gravid patient who may desire to carry that pregnancy. In other words, the placenta's identity as a friend outweighs its identity as a foe. And assuming it is indeed desired, the pregnancy may therefore be expectantly managed until fetal delivery, when the placenta separates or is removed, since it no longer has any life-giving potential. If it remains pathologically adherent, it is exclusively a foe and now only has life-taking potential. Obstetricians are trained to recognize clinical scenarios when the identity of the placenta as a foe outweighs its identity as a friend, and expedited delivery may be recommended, such as acute hemorrhage or from a placental abruption or an eclamptic seizure. The principle of double effect is an ethical doctrine that has been used to justify an unintended consequence of an action if a beneficial consequence of the same action is intended. There are several criteria to evaluate an action. First, the action is morally neutral and has inseparable consequences. Second, the beneficial outcome is intended. Third, the harmful outcome is outweighed by the beneficial outcome. And fourth, due diligence is used to minimize the effect of the unintended outcome. The application of the principle of double effect is as routine as chemotherapy. A cytotoxic infusion is administered. The intention of the chemotherapeutic infusion is to prevent aberrant cellular growth of the tumor. There are unintended consequences, such as nausea, which to some degree are inevitable. However, the intended outcome, reducing the tumor burden, may be of greater proportion in the eyes of the patient than the unintended outcome. Additionally, the unintended harm of nausea is attempted to be minimized with antiemetics or nutritional supplementation. Let's now apply this principle of double effect within the context of a hypothetical case of Ms. Smith. Ms. Smith is a 21-year-old woman with severe lupus, including shrinking lung syndrome and a history of venous thromboembolism. For her lupus, she's taking hydroxychloroquine and azathioprine. Given her history of venous thromboembolism, she's taking prophylactic enoxaparin. And to reduce her risk of preeclampsia, she's on aspirin. Her baseline labs are normal, including her 24-hour urine and her baseline creatinine. At 23 weeks gestation, she has a blood pressure of 164/104 in clinic, which is severely high for a pregnant patient and requires inpatient admission for treatment and observation. Based on blood pressure criteria, she is diagnosed with preeclampsia with severe features with a plan for expectant management. 5 days later, she's 23 weeks and 5 days gestation. And during routine laboratory surveillance, there's an elevation in her creatinine. Rheumatology is consulted, and because she has no history of lupus nephritis and normal complement levels, feel that her acute kidney injury cannot be due to a lupus flare. In the next set of labs, her platelet count is now 46,000, further supporting the diagnosis of preeclampsia. Delivery is now recommended. Why is delivery recommended? Ms. Smith has preeclampsia with severe features. And while the precise pathophysiology of preeclampsia is unknown, the leading theory is that it is due to poor placental perfusion leading to oxidative stress, hypoxic endothelial conditions, and systemic anti-angiogenesis. Even when we do not know what causes preeclampsia, we know that delivery cures it. And more pointedly, the removal of the placenta is critical to the cure of disease. And in fact, when we recommend delivery, we are precisely recommending a placentectomy. The placenta is the source of disease. And in the case of Ms. Smith, the placenta's threat as a foe now outweighs its relationship as a friend. And at this point, the placenta must be removed, just as a diseased appendix must be excised to preserve bodily integrity. A placentectomy leads to cure of the disease. Of course, the action of a placentectomy does not affect the gravid patient alone. The action of removing a placenta consequently removes its downstream end, the fetus. At 23 weeks, a placentectomy may be performed either by dilation and evacuation, a hysterotomy with a manual extraction or cesarean delivery, or an induction of labor with either spontaneous or manual removal of the placenta. Each intervention carries its own risks and benefits, and shared decision-making is imperative, as a patient may value certain aspects of each intervention over others. At this gestational age, the fetus is at high risk for neonatal mortality or serious long-term morbidity. Regardless of the surgical or medical approach taken, a commonality with all three approaches is that a placentectomy brings about the goal of therapy of preserving Ms. Smith's life, because the harmful reality is that the placenta is now life-taking and outweighing the dwindling life-giving potential. Returning to the case of Ms. Smith, she initially declines delivery because her cousin was born prematurely and has significant hearing loss as a result. She also wants to remain pregnant as long as possible for her baby to grow. The clinician with empathy notes that the clinical picture is rapidly changing, as evidenced by dropping platelets and a rising creatinine. The clinician shares that she has no intent to deliver a baby this early and can't promise that hearing loss won't happen or even another worse outcome. But because of a significant placental disease, prolonging the pregnancy is becoming dangerous to her and subsequently to her baby. The placenta is effectively becoming a foe to the fetus as well. Shifting the focus of a disease burden from the pregnancy to specifically the placenta, the clinician is able to provide reassurance that the intention behind a placentectomy is to preserve Ms. Smith's kidney function and prevent further morbidity or even mortality in her. She's offered 3 different approaches for placentectomy, and after thought, Ms. Smith agrees to pursue a placentectomy through an induction of labor. She is induced and she delivers a 431-gram neonate who's intubated and cared for in the NICU. She's placed on postpartum magnesium, and over the next 2 days, her renal function improves to baseline and platelet count also begins to normalize. She is discharged in postpartum day 4 and is frequently seen in the NICU. In her case, the intervention of a placentectomy has 2 inseparable consequences, with definitive treatment of her preeclampsia intended and the unintended outcome of iatrogenic prematurity. Definitive treatment of preeclampsia is proportionately more beneficial to both Ms. Smith and her baby than iatrogenic prematurity. The latter is attempted to be minimized with steroids for pulmonary advancement and delivery with proximity to the NICU. Using the term placentectomy, we utilize existing medical terminology to discuss anatomic processes, structures, conditions, and treatment. The suffix ectomy comes from the Greek meaning excision. It is the equivalent to the combination of ek, meaning out, and tomi, meaning a cutting. Therefore, a placentectomy on a fundamental level describes a procedure to remove a placenta, a standard of care, in order to preserve health. We're able to draw a linear cause and effect outcome from removing her placenta to the treatment of preeclampsia, similar to removing an infected appendix treats appendicitis. The approach may be open or laparoscopic for an appendectomy, but regardless of the approach taken, the intent of the appendectomy is the same. Both the terms appendectomy and placentectomy describe an intended purpose of a medical procedure or intervention to remove a diseased organ. There are several strengths in this model which draw on the principal double effect. First and foremost, in the counseling of patients with high-risk pregnancies and highly anticipated pregnancies, shifting the focus of disease specifically to the placenta may be helpful in informing shared decision-making. Ms. Smith does not see her pregnancy as a disease. In fact, in my experience, when patients hear the word pregnancy, they think of their baby. Acknowledging the placenta as a third component in otherwise binary maternal-fetal relationship, we would more clearly delineate the source of preeclampsia for her. Second, it is a pragmatic, boots-on-the-ground model in the care of high-risk pregnancies that might avoid entanglement in an environment where political assaults are being made on those who are pregnant. And third, by adding placenta as a critical component in decision-making, it provides an important alternative to the maternal fetal conflict model that has dominated medical ethics conversations. Understanding Miss Smith's disease as between her and her placenta rather than between her and her intended child is a more accurate model than one that pits maternal and fetal interests against each other. There are important considerations to this model that render of limited utility and are dependent on other ethical frameworks. The principle of double effect may place a disproportionate attention on intent rather than consequences. The intent may be clear in certain circumstances like an eclamptic seizure, but it is important to emphasize that cases that fall outside this are justifiable on the basis of other ethical frameworks such as reproductive justice. A placentectomy may be the medical recommendation based on extensive training and experience in high-risk pregnancies. However, the patient is the penultimate expert in their narrative. And while framing placental removal as treatment of disease may be helpful in informing the patient, the ultimate decision is hers. Next, the dual identity of the placenta as a friend and foe takes an obviously reductionist approach. Of course, the relationship between a pregnant patient and the placenta goes beyond a purely organic one. The placenta holds a potential child, and therefore the patient may be a potential parent. There are emotional complexities that a potential parent places in the placenta that are not captured from looking at the placenta purely from a materialist lens. From this perspective, it also does not account for sociocultural relationships with the placenta that go beyond the placenta as a trophoblastic organ. In conclusion, we discussed the dual potentialities of the placenta as a friend and as a foe, and using the principle double effect, we demonstrated how these may be used in counseling complex maternal fetal medicine cases, such as the case of Ms. Smith. We propose the term placentectomy similar to appendectomy and review the strengths and limitations of this model. Thank you to my mentors for this project, Dr. Annie Lyerly of the University of North Carolina, who's my main ethics mentor, Dr. Evan Myers and Dr. Brett Einerson, who are content experts in decision-making analysis. Dr. Elistad, who's my program director, has been an unwavering support for granting me space to pursue clinical ethics. And while I didn't put this in my slide, I'd like to thank my MacLean co-fellows. I expect our friendship to withstand the test of time. Thank you. Great. Great. I'd love to hear people's thoughts. I'm excited for Dr. Kaur's thoughts.
Great. Okay, thanks. Luke, this was so thoughtful. I'm really just incredibly impressed by your talk. I look forward to further, I'm so sorry, I can't really talk. I look forward to further engagement on this. One other strength that I would include is that focusing on the placenta not only takes kind of shifts away from blaming or placing blame on the pregnancy, but most importantly on the pregnant person. Because when something goes awry in a pregnancy, we all know that the pregnant person is first and foremost blaming herself and looking for ways that she messed up or they messed up. And so I think that that is a really nice strength in this model. I would be so eager to explore with you kind of what how patients would respond to this kind of, concept or language or, kind of where patients are around this. And I do think that talking about complex pregnancy, medically complicated pregnancies in this way, again, would relieve some of the burden. It'll be really interesting to see how digestible it is in kind of, like theory versus practice. I think that'll be a really interesting thing to explore. So thank you. And the other thing is that unfortunately, one of those options is going to be off the table in a lot of these discussions. And that's D&E and then induction termination, which wasn't on your slide. The induction that you had listed seems to be induction with the intent of a live birth. But induction termination is also on there. And that, of course, shifts the narrative. Even with your, I appreciate your optimism that using this model may make discussions around this a little bit safer in abortion restrictive states. Not, see if that works. But certainly some of those options are really going to be off the table for many patients.
Yeah. Well, thank you. And I know that you think about this stuff every day. So this is, I think, important. There is a risk whenever in the physician-patient relationship or clinician-patient relationship, patients oftentimes feel badgered, when we're saying like, you have this disease, it's getting worse, and there is this hope. And I know that whatever field that you're in, that there is a risk of kind of hitting the patients over and over again with counseling. And this is a true story. But there was a patient who had a very severe disease and was bleeding and getting transfused, and she was pre-viable. And it dawned on me that when she was hearing that the pregnancy, we were effectively recommending termination of pregnancy, and when she recognized that it wasn't her fault, but also wasn't her baby's fault, it became a very palatable intervention. So at this point, that's where the placentectomy, it's a common foe. And, we can frame it as such that can alleviate patient moral distress and many clinicians' moral distress as well. So thank you for your work.
One question from Dr. Kodish. Dr. Kodish in the back.
Yeah, that's great.
Thank you. Terrific talk. And I love the use of double effect more broadly than just end of life care, which is sort of our go-to place for it in clinical ethics. My question is about pre-viability, and if you can spend, your narrative chose a 23-weeker, fair enough. What if your narrative is a 16-weeker, or to complicate it further, 16-weeker in a state where abortion is now illegal?
Just this past week, on a patient with ER-positive breast cancer who was about that same gestational age. And when we looked at, I used the word placentectomy for her as well. She had a highly anticipated pregnancy, and when we framed her hormonal treatment, hormonal therapy, we recognized that the source of disease was also hormonally responsive placenta. And so again, the model still worked in that circumstance as well. So this model works for really narrow conditions, and those are maternal conditions. But how that plays out in real life, that's well above my pay grade. Thank you.
Thank you very much. Okay, our next speaker is Dr. Howell. He's going to be talking about what can 21st century clinical investigators learn from the 19th century human experimentation. He is a Robert Wood Johnson Clinical Scholar. He is currently a professor of the history of medicine and a professor in the departments of internal medicine, history, health management, and policy. He runs the medical arts program, and he wrote a book called Washita County Bike Rides.
Thanks, and I just want to second what everybody else said. That Luke, that was really a tremendous talk. It's given me lots to think about. So let's start this story. This is an often told story. It starts about 200 years ago, about 500 miles north and east of Chicago on Mackinac Island. The two central characters are Alexis St. Martin, a French-Canadian fur trader, and William Beaumont, a young, not particularly well-trained Army physician. They first met outside this general store on Mackinac Island. Mackinac Island is north of Michigan. Michigan was not yet a state. It's a tiny, tiny island, one of the most isolated places where the United States Army had a post. The fort dominated the view as you looked at the island, a little closer look at the harbor. And on a beautiful summer day, about 200 years ago, a shotgun unexpectedly went off into Alexis St. Martin's side from only about a foot or two away, with what appeared at the time to be almost certainly fatal consequences. But somehow St. Martin survived. And from the moment of that shotgun blast onwards, Alexis St. Martin and William Beaumont were fated forever to be linked in physical life for the next 33 years and in the history of medicine for centuries thereafter. Now, if clinical ethics, as Peter suggested this morning and as Mark has written, is about the relationships between doctor and patient, a one-on-one, non-theoretical in real time, then I'm going to argue that this relationship between Alexis St. Martin and William Beaumont may have been an early example of the utility of clinical ethics, or maybe not. We'll get to it. All in all, Beaumont did 238 experiments, putting stuff in the stomach, pulling stuff out of the stomach, taking gastric juice out of the stomach, and on that way, fundamentally transforming our understanding of gastroenterology. Beaumont was born in Lebanon, Connecticut, only a few years after the end of the Revolutionary War. He made his way to Champlain on the Canadian border. As a small-town schoolmaster, he liked to read books. He trained as a physician by apprenticing to a local GP. This was fairly standard way of training to be a doctor. Soon thereafter, in 1812, a war started between the United States and Britain. You get no bonus points for identifying the name of this war. It's the War of 1812. And Beaumont joined the Army as a way of achieving professional advancement. This is the Battle of Plattsburgh. He was extremely active. He cut and slashed. He did trephinations. He did amputations. Bear in mind, he's doing amputations here without anesthesia, without antisepsis. Battlefront amputations were no joke. The war, we've forgotten what happened during the war. We went north and burned down the Parliament buildings of Canada. In response, the British Army came south and burned down Washington, D.C. But war finally ended in 1814. And Beaumont went back to Plattsburgh, where he set up practice for 5 years. This is the announcement of his practice. However, times got tough. There was an economic downturn, and he turned to Joseph Lovell. Joseph Lovell had been the head of the hospital he worked in during the War of 1812, and Lovell had recently become the new Surgeon General. New in many ways, he was the first Surgeon General. He said, I want a job. Lovell didn't have a great job for him, but the best he could do was as a post surgeon on a distant island. Beaumont then traveled from upstate New York to Mackinac Island. He did so on the Erie Canal, which is worth mentioning in any historical talk. Truly a phenomenal creation. In 1817, it was started 363 miles from Albany to Buffalo, bringing Great Lakes produce to New York City and the East Coast, and also illustrating the role of the government in creating works of science and architecture. Beaumont was thus exposed to the latest in technology on his way up there. There's more Erie Canal. Stopped off briefly at Detroit, took the famous steamship, the Walk in the Water, up to Mackinac Island, and finally got there at one of the most isolated places the United States Army had a post. So let's now turn to what happened and ask how Beaumont, seemingly an unlikely character to enter the pantheon of medical history, was transformed into the sort of person that will merit some attention for the next few minutes. Consider, he wasn't particularly well trained. He certainly was not in a league with notable US physicians, many of whom had actually gone to medical school, had actually gone abroad to Europe to study science. Furthermore, he's off in the middle of nowhere. He doesn't have a library. His internet connection is unstable. He doesn't have colleagues to work with. It's hardly a place you would think of as advancing medical science, and yet opportunity knocked. As Alexis St. Martin was waiting in line to sell his goods, he was a fur trapper, a carelessly loaded musket went off into his left side. Beaumont arrived within minutes. He arrived to see Beaumont's breakfast literally spilling out on the ground. This is an image from much later after the wound had healed. Every time St. Martin coughed, a piece of his lung came out. Beaumont extracted part of the shot as well as pieces of clothing and left with the words, "The man cannot live 36 hours." So he had pretty bad prognosis, but then it got worse. He developed a violent pneumonia with cough and fever. Even today, we would consider this something worthy of attention. Beaumont treated him in the traditional way, first by bleeding him 12 to 14 ounces and by giving him a cathartic. This was standard treatment in the day. We can talk about why if you wish. The problem was when he gave him the cathartic, it just came out the hole in the stomach. So it didn't have any effect. The wound became very fetid. He couldn't take anything by mouth. So Beaumont fed him with anal injections, which had to not only supply his baseline caloric needs, but also the caloric needs necessary to heal the wound. You can actually do that. It surprised me, but you can. And amazingly, Beaumont recovered. And there was a union between the stomach and the intercostal muscles, but it left a hole that appeared went to the outside. He got sick again. This time Beaumont treated him and administered the medication by pouring it through his ribs into the stomach directly, and it worked. At this point, St. Martin was better. He was declared a common pauper. County refused to care for him, and Beaumont said, "I'll let you stay in my household if you'll do chores, help out with the washing, gather the wood, etc." So he sent his old friend Lovell, now the Surgeon General, a manuscript. I know you can't read it, but we historians, we love to read other people's mail. That's what we do for a living. And it's a lot. And this is a letter he sent to Lovell saying, "This is what I've got." And Lovell responded enthusiastically and suggested a lot of experiments that could perhaps be done using Alexis St. Martin. Now, before going more deeply into the experiments, let's pause for a moment about what people understood about the stomach. There had been debates about the stomach and digestion going on for centuries. In the mid-19th century, the debates raged between those who said it was a mechanical process or it was a chemical one. People had done experiments in which they had birds swallow sponges and then have the birds regurgitate the sponges and wring out the gastric acid and show that there was acidic fluid. I don't know how you convince a bird to regurgitate a sponge. People took out the gastric juices and showed that they acted to digest the food more effectively outside the body or inside the body than out. But other people argued, other people were vitalists and said there's something vital about digestion, that you can't really understand it outside of a living human body. Other people said, you say there's acid in the stomach, that makes no sense. If there was acid in the stomach, it would just dissolve it. Exactly, it would just eat itself up. I've raised these objections not because I don't believe there's acid in the stomach, but because you should think about these are rational objections. These are rational reasons to doubt common wisdom. It was an active conflict in Europe. The French Academy of Sciences sponsored a contest, but Beaumont didn't know anything about this. He didn't have any literature, but he did have access to a stomach. So what did he do? As he went around to various army posts, he took Alexis St. Martin with him. The first set of experiments were very brief. This is the report that he published. We'll look at it close up, and it basically says he put in food, beef, pork, stale bread, raw cabbage, and he pulled out every now and then to see what was happening to the food. And what happened is Alexis St. Martin got very sick. Did the same thing with the beef inside of St. Martin and found that it digested faster. Now, note on this report, and we're going to come back to this point, that he tells you the date, the time, and other places he's going to tell you the temperature, the barometric pressure, and he's going to note that Alexis St. Martin continues to work as a servant while he's having these experiments done. It's a great start. It gets interrupted by life. This is not, there we go. No. It's a great start. It gets interrupted by life. Alexis St. Martin heads back to Canada. In the meantime, Beaumont is involved in another ethical issue. In Fort Niagara, a lieutenant by the name of Edmund Griswold reported in sick and insisted on being put on the sick list. Beaumont thought he was malingering. I'm trying to get this thing to kill the, there we go. Beaumont thought it was malingering, so was trying to get out of his military service by claiming to be sick when he wasn't. So he gave him a gargantuan dose of what he called an emetic cathartic, that is a medicine that would most make him vomit and have diarrhea. Would have got him really sick. Well, Griswold didn't get sick. So Beaumont said, "You're not really sick. You're malingering," and Griswold was court-martialed and dismissed. However, people were concerned about the ethics of what Beaumont did, and the case made its all the way up to the 6th president of the United States, John Quincy Adams, not to be confused with his father, the 2nd president. And Adams, imagine this is an Army surgeon who's got ethical issues going to the President of the United States, who thought that this was horrible. Said more than doubtful propriety in the relations of a medical advisor to his patient. A medicine of violent operation administered by a physician to a man who he believes to be in full health is a very improper test of the sincerity of the patient's complaints. And the avowal of it as a transaction justifiable in itself discloses a mind warped by ill will or insensitive to its own relative duties. Now, I'm going to come back to this, but just note where Adams identifies the problem with Beaumont. It's not an informed consent. It's not in rights. It's inside his mind that he has a mind warped by ill will. And as I was preparing this talk here, I couldn't help but think of the late, great, esteemed Charles Bosque, who in his book, Forgive and Remember, a study of surgeons at a place not unlike where we now find ourselves, identified one of the main ethical problems that surgeons had. Not what weren't errors of technique or errors of judgment, but having a mind warped by ill will or insensitive to its own relative duties. So it's a nice corollary, I thought. So Beaumont continues doing experiments. Alexis St. Martin continues working as a house servant. Here you'll note, again, he notes the temperature, he notes the mercury, he notes the weather. Here's another report in which he notes that the fluid tasted slightly acid, an interesting way to go about doing scientific research. Keeps putting food in and out, gastric juice and water. We don't have time to go into all the experiments in detail. St. Martin's wife gets homesick. He decides to head for home. And he goes from the confluence of the Wisconsin and Mississippi rivers up the Mississippi, the Ohio, Lakes Erie, Lake Ontario, and the St. Lawrence River all the way to Montreal in an open canoe with 2 children and his spouse. One hell of a trip. Beaumont asks permission to go and do some more work. He heads to Washington, D.C., gets Alexis St. Martin to come back and spend time with him. This time, they sign a contract. And St. Martin agrees that for 1 year, he'll serve, abide, and continue with Beaumont, and agrees to be a subject in medical experiments. And for this, he gets room and board and $150. Finally, Beaumont winds up in Washington. He's away from frontier isolation. He arranges for St. Martin to enlist in the Army. His duties basically are to be a human subject. Beaumont tries to get money from Congress, and Congress refuses to give him money, says there's no constitutional way for the United States government to support scientific research. It's important to realize, folks, as we stand here under the aegis of the National Institutes of Health and their outrageous indirect costs that support my medical center and yours, that this is a very recent phenomenon. This is in terms of the history of medicine, this has only been recently. Here, the government considered supporting this and said, no, we don't do that. Here's the book, 280 pages, Experiments and Observations on the Gastric Juice. It's dedicated to Lovell, perhaps no dedication more richly deserved. His most important conclusions: confirmed that hydrochloric acid was important, recognized the gastric juice were separate, established the influence of mental disturbances, and finally at the bottom, probably the most important, he showed that digestion was the result of a chemical process as compared with vitalistic processes. Literally a pioneer scientist, arguably the first American physiologist, as basic science could be during the 19th century. Beaumont moved on, went to St. Louis, fell down some icy stairs and broke his hip and died. Alexis St. Martin went back to Canada. Beaumont kept trying to get him to come back to do more experiments. He said, no, thank you. Phineas Taylor Barnum of Barnum and Bailey Circus tried to get Alexis St. Martin to join the circus. You can just imagine the exhibit, come and see the man with the hole in his stomach. He said, no, thank you. When St. Martin died, William Osler tried to get his body for the Medical Museum in Washington. They didn't want any part of it, his family. They left it outside in the hot weather so that it would decompose a little more than usual and buried it deeper than usual. Throughout all this, and this is Alexis St. Martin near the end of his life, Beaumont was struggling with issues relating to isolation, difficulties supporting his research we've mentioned, and for generations to come, people would do science while holding down other jobs. But How should we consider the ethics of Beaumont's relationship with St. Martin? This is a monument on Mackinac Island to William Beaumont. The answer is that the ethics has changed over time. And here I am, a historian talking to a group of ethicists and suggesting that the ethical codes that we like to quote are in fact contingent, historical, cultural, and temporary. And this as opposed to being some kind of platonic ideals that will forever or ought forever to get to mediate relationships between human beings. Beaumont thought about the ethics of what he was doing. He said it was proceeding from motives which my conscience approves. So we thought about this. What am I doing? He said the experiments were executed in obedience to the dictates of humanity and a desire to benefit community and perpetuate the advantages of this signal opportunity for physiological improvement. In other words, he was justifying this on the basis of the knowledge that he was going to gain. And this is a justification that has been used many times over the centuries to come. I think of the Willowbrook experiments, an incredibly contentious series of experiments in which one group of people says what you did was absolutely horrible, and somebody else says, yeah, but look what we learned. We learned really important stuff. Does that make it okay? You're the ethicist, you decide. Others emphasized Beaumont's benevolence, and interestingly enough, the inconvenience that was posed not for St. Martin, but for Beaumont. This is William Osler describing it, altogether helpless and suffering under debilitating attacks of his wounds, naked and destitute of everything. It almost has a religious tone to it. Beaumont cared for him at much inconvenience and expense. Forget what happened to Alexis St. Martin. This cost Beaumont a lot of money. It was really hard. And he talks about the disinterested labors in the cause of humanity and science. Later on, after experiments at Willowbrook and Tuskegee came to light, ethicists started to question the relationship. Beaumont tried to make it sound as though he took in St. Martin before realizing all the fun stuff he could do with his stomach. Others suggested that the order was reversed, that he took in St. Martin precisely in order to be able to do experiments on him. The experiments clearly caused St. Martin considerable pain. The United States journals, medical journals, tended not to notice this very much. British and Irish journals were much more concerned. The London Athenaeum in April 1854, for example, commented that Beaumont, in his haste to make observations, forgot that he was operating on a living, irritable human subject. How seriously was St. Martin harmed? Beaumont went to great lengths to point out that he stayed healthy. How should we do retrospective judgments? I think the best discussion of this probably comes from the President's Commission on the Radiation Experiments, which makes a great deal of looking at existing codes. There were no ethical codes here. There were not even the medical codes. There were no state licensure laws. But historian Alexa Green, in this wonderful article, suggests that the research ethics of the time was centered on ideas of employment and servitude. That St. Martin was brought in as a domestic servant. His rights, such as they were, came from his relationship with St. Beaumont. And we can see evidence of this in the Articles of Agreement, in which he said he would serve and abide and continue and do and perform such service in business matters. These are rights of an employer and a subordinate, not a 21st century idea of rights of patients. So I would raise a question here simply about whether we are looking here at a doctor-patient relationship, whether this is clinical ethics in its early years, or if we're looking at a relationship between an employer and a servant and how you treat somebody who's working for you. And I think that's an important distinction to make. Other ethical questions we don't have time to go into in detail, questions about who should be memorialized, whether we should have this memorial to him, whether we should put one up for Alexis St. Martin. Other ethical issues we don't have time to go into either. I was fascinated by President Adams critiquing Beaumont, not for any of the terms we would, but for having a warped mind. Just as in science, ethics is made in every generation using the available tools. I'll point out the scientific ethos here was to include the time and the temperature and the barometric pressure. Just as science was a different world there, ethics was also a different world. We would think here of gender, socioeconomic status. We've talked about a great deal today. And this historical lesson should simply make us think about how ethics and science are all inextricably embedded in a particular social and political and economic context, and that we need to bear that always in mind as we think about what we're going to do going forward. And I'll leave you with this view of Mackinac Island on a nice sunny day in the 19th century.
So if people have questions, maybe they can come up afterwards, because we're done for this session now, and then we'll regroup at 4:20 and talk about the pandemic and ethics during the pandemic. So stay around. Yeah, thank you. Interesting.
Didn't realize it's taking all this long, whole 20 years.
You know, it's working out like a clock, and it's
There ought to be a
15.
clock.